which is ATA member connection, and this will also be emailed to all registrants after today. That said, I'd like to turn the presentation now over to Joanna Braunold, Director of Content Marketing and Communications at TytoCare. Joanna.
Thank you very much, Brian, and thank you very much to ATA for hosting us today. I'm excited to welcome everyone to the webinar, and I'm really looking forward to the conversation we're going to have with our esteemed speakers today. So I want to start us off with some introductions. Rima, would you like to kick us off?
Absolutely. Good morning, good evening, good afternoon. I am Rima. I'm a primary care physician and an internist by training, and also serve as the Chief Medical Officer for Orwell Health West for ambulatory and population health. Very nice to be here.
Thank you so much, Rima. And Stephanie? Stephanie, you're on mute.
There we go. Sorry about that. Hi, everyone. Stephanie Lewis, registered nurse by trade. And in my career, I've had the humble opportunity to work across very many different domains, including clinical practice, health informatics, IT, EMR, leadership, and virtual care initiatives. Currently, I'm the Senior Director of Enterprise Telehealth and at Orlando Health, and I'm involved in developing and implementing many of our virtual services across our ambulatory and post-acute division. And I look forward to our discussion with my esteemed colleagues here, Rima and Dr. Wells as well. So thanks for having me.
Thank you so much, Stephanie. And Alvin.
Yes, hi. My name is Alvin Wells. I'm a board-certified rheumatologist. I'm the Midwest Region Director for Advocate Aurora Healthcare. I have a department of 22 providers across the states of Illinois, Wisconsin. We do both adult and pediatric rheumatology. And one of the projects we've been working on since 2017 is virtual care. We've been doing telemedicine since that time. We have a license in 7 different states, and we'll talk about how we've been leveraging TytoCare across the Midwest region.
Thank you so much. So let's get into our discussion. I'm going to start with a question and ask everyone to share their thoughts with me, with us. So how central do you see the role of digital health in future-proofing care delivery? And can you share an example of how you're leveraging or planning to leverage digital health in this way? Should we start with you, Alvin?
Yeah, so the question is, well, how do people define digital health? I mean, the terms that we're using, I think almost interchangeably, when they talk about digital health, artificial intelligence, telemedicine, all those things are in that same realm, under that same type of umbrella. And I think here we are getting to the precipice of going to 2025. And I think if organizations, if even private practice doctors are not doing a digital health, have a digital health component, unfortunately, they're going to be left behind. Our patients are demanding this. They want to have ready access. They need to see a specialist today, not tomorrow or 6 months. And how do we leverage digital health? One of the things we talk about, how do we tier patients who need to be seen in 7 days, who can wait 3 weeks, who can wait 3 months? And that's where digital health plays a role. So I think is a part of our aspects of how we do clinic. I have a faculty appointment at Duke University. I was there last month doing, talk about innovations in rheumatology care. And one of the things we talked about, how they should really rev up and change their rheumatology clinics. And I was really pleased that one of the attendants said, hey, we've been doing rheumatology like this for 40 years. Maybe it is time we start adapting digital health and get into the new forefront of where we are in medicine. We'll share some of those more thoughts with you as we move along.
Thank you so much. Shall we go to Stephanie next?
Yeah, Dr. Wells, I think you hit a thread of a keyword I wanted to point out from what you just said was innovation. And I want to add another word there, adaptation. And I think digital health solutions really kind of pave the way to help organizations constantly evolve and drive innovation in treatment methods, whether that's diagnostic tools or even different patient care models. And if any of you on this webinar have been to a conference lately, I think we're all seeing the proliferation of artificial intelligence and it kind of feels like a soup of AI and LLMs and all of these buzzy words, powered by AI, driven by AI, clinical decision support by AI. And I think we need to, not only future-proof delivery with innovations like AI, but I think we need to be also cautiously embracing it. And as leaders in the healthcare space, we have to start learning how these tools can help us drive that innovation and patient outcomes, but then also understand how these models are built so that we can remove any bias or inequities as we use this type of technology as well. And, as an example of how we're doing that here at Orlando Health, we use clinical decision support tools such as detecting strokes. And, when we have layers of AI and large databases to pull from, we can start cascades such as rapid notifications to providers to initiate stroke alerts and, time is tissue and improve those patient outcomes. And then specifically within my service line, we use predictive analytics so that we can predict patient outcomes, such as high-risk readmissions. We have a high-risk readmission rate that we can kind of target populations of patients and make sure that we can get remote patient monitoring tools or other telehealth or digital tools to those patients in high-risk populations.
Thank you very much. And Rima?
Yeah, absolutely agree with my esteemed colleagues here. Couldn't agree more with innovation, and we need to embrace it. And of course, the term of technology, digital, is a basket term. There's so much that goes into it. But when I think about access, when we think about convenience, when we think about workforce, I think that digital technology is going to be so important in solving for a lot of these as one of the solutions for some of those issues that we are seeing. We know that healthcare, we know that our populations are aging, so that the demand for access is so much important. We know that healthcare is becoming costly, so how can we leverage technology and provide that access and also prevent unnecessary emergency department visits, hospitalizations by being more proactive than reactive? And how can we do that to some of the things that Stephanie mentioned as well? And then I think workforce, we know that workforce is shrinking, physicians and APPs, we don't have enough of anymore, whereas the demand is increasing. So how do we take away a lot of the redundant work that can be done in other ways and let our team members and our physicians, APPs, to perform at the highest level? I think those are so important. And then the other thing is not only help deliver healthcare, but how do we also help our providers take away the burnout that they are experiencing? A lot of technology available, such as the Nuance AI technology that is available, where it just generates the notes as you're taking history from our patients, and we have implemented that. What it does is it lets now our providers be able to see more patients rather than just documenting. We were seeing our providers cutting down on their FTEs, going part-time, and that was shrinking, making access even worse. So there are so many different ways that we can really leverage technology, leverage our digital delivery processes to help with that. So.
Thank you so much, Rima, and thank you to everyone. I think you all mentioned different ways that your organizations are using all of the different forms of digital health, because of course it does, that phrase digital health does encompass so much now, to solve problems that you and health systems across the US are facing. So I want to dive into that a little bit. Can you share how your organizations balance the need for operational efficiency, like reducing costs, with maintaining or improving the quality of care?
Sure, and I can start too as well. So one of the things I think most places now, they have a patient-centered application, an app. So we have one called Live Well with our thing. And what that does, it cuts down the messages that go to my end basket. Patients can ask for refills, they can schedule an appointment, they can do all those different things that I would, that would take a phone call in the past. and it puts the patient in hand. I think Rima had another term, say we talk about empowering patients. And I think that's one of the things that we really want to see and how we leverage that with our group. I think one of the other things we've done is say, hey, using these digital things, I'm seeing some models that are popping up in private care groups where, hey, think about this. And we learned this during the pandemic that I don't have to have an actual individual sitting back here in my room working. That individual could be at home. And a lot of private practice doctors are leveraging that technology, and they're actually hiring nurses and other staffs from other countries. It could be from the Philippines, it could be from wherever. That they can get that staff, and those people can do things that it will cost, $40 an hour here, including benefits and everything else. You get somebody for $8 to $10 an hour. That person can be used to leverage to make phone call reminders for your patients. That person can be used to do your prior authorizations because they don't generate money, but they take up a lot of time. So all those digital tools that are there, I think is really something that's really amazing. And I think Rima touched on one other thing, talk about artificial intelligence, the DAX, the nuance. I mean, this is what's been game changers. I can walk into a room, I can start talking to that patient. It can tell the patient's voice versus my voice. And it screens out things if the patient starts talking about a birthday cake or their cat, but it tells me if you have left knee pain, they have pain when they have difficulty sleeping, all those things are programmed in there. And Rima hit the nail on the head. It allows me to focus on the patient as opposed to doing like this, looking at the computer and looking at my time. I only have 15 minutes for a follow-up. And that's what's exciting about digital health. And as we bring these things forward for all of our providers to give them that work-life balance that we struggle with.
I think that's a really key insight, especially on the AI side. As it's coming into use across all fields, I think our goal is to get it to do the things that we don't want to do and not the things that we do want to do, right? From a creativity perspective, for me, it's not about getting it to, design things or write content for me. It's about getting it to do the bits that are difficult and time consuming. And I think that's a really great point about how we can use it to serve clinicians. Rima or Stephanie, would one of you like to jump in next?
Yeah, sure. Thank you, Joanna. At Orlando Health, we really have a mission to improve the health and quality of the communities we serve. And we have a really high focus on quality and safety in everything that we do. And we're held accountable to it as well. And I think when we're trying to balance efficiencies and reducing cost, I think we have to always go back to the basics and making sure that we're serving our patients and our customers as well as we can by, improving those outcomes, and patient experience and satisfaction kind of comes into that as well. And if you can get those all aligned, the trickle down effect, it is hands down, you can't calculate that. And I think specifically for me at Orlando Health, one of the prime examples of that is I oversee our remote patient monitoring team for chronic disease management of heart failure, and we've had that around for about 12 years. And I think it's important when you start asking yourself those questions, how can we maintain quality and reduce cost? Not every program that you're about to design or implement may have a green line on your P&L, and I think you have to work with your stakeholders and define what your KPI or, tell that story about what the value add and how you define that for that virtual care program that you are trying to support. Even though it may not necessarily be profitable, it may be a cost saver. And I think specifically for us, we've seen anywhere between 1% to 3% readmission rates for our Medicare fee-for-service population in heart failure, which is well below the national average that we're seeing out there across other programs. And I think as well, when you start looking at, the efficiencies of what technologies such as RPM for chronic disease management can do, you can see some of those efficiencies come through the data by reducing inpatient admissions. And we've seen a 50% reduction in our slice of census of patients. And then you're also seeing, where you could have upwards of millions of dollars in gross charges for HB and PB. And we're seeing significant reductions in post costs for our patients who have had RPM services. So and just with the simple automated care plan over 90 days, we can really engage with our patients a lot better. And, I heard that word empower our patients to be more in tune with their health status post-acute before they get to their primary care office, or in collaboration with our heart and vascular team. And then we have our nurses outreaching to make sure that those patients are staying compliant as well, and that we can gain reimbursement for the services that we're providing. Overall, we're seeing a lot of efficiencies, throughout the enterprise, reduced visits, reduced inpatient admissions, and even seeing ED and urgent care and office visit diversion as well. So a lot of really great benefits just from that one use case.
Yeah, so I couldn't agree more again, Stephanie, with you. I think the incentives, alignment of our incentives, when we look at fee for service, the world that we function in, it is hard to show, what is the revenue that you're generating with some of these projects or the work that we're doing. But when you look at value, right, how can we improve quality and decrease the cost of care, and looking at outcomes of our patients? When you really focus on outcomes, it completely changes the game. And anything that we can do to focus on those outcomes, to make sure we are reducing unnecessary emergency department visits, unnecessary readmissions. How can we be more proactive and not wait until the patient is decompensating and showing up in the emergency room? How can we provide that care in a timely way? Once you are seeing those red flags, and that's when you can intervene and prevent those. When you look at it from that point of view, it all makes sense. Remote patient monitoring makes sense. Keeping care local, we have a lot of regional hospitals who may not have all the skills or the specialty in those hospitals, but we can use technology, and we have had virtual ICU, which is providing ICU virtually to some of these remote hospitals who may not have pulmonary critical care or other specialties. And we have seen outcomes being better that way. Instead of having to transfer those patients from regional hospitals, they can be really managed virtually through virtual ICU. So I think when we focus on those incentives of what is the right thing for the patient, what are the outcomes we are looking for, improving the quality, and hey, by the way, also reducing the cost of care.
Well, let me chime in one other thing, because I think both Rima and Stephanie touched on something. We talk about outcomes, and it's using digital tools. I'll give you another good example. We're trying to say if a patient gets admitted to the hospital for gout, a very, very painful disease diagnosis. These patients walk into the emergency room where it costs, $1,000 for that visit. What we find is some of those patients that get treated for that acute episode, and unfortunately, for whatever reason, there's some literacy issues, access to pharmacy issues, all of those different things, and that patient doesn't get the medication. And that patient ends back up in the emergency room instead of in my clinic or in Dr. Shah's clinic. So the question is, can we use a digital tool? Can there be a reminder to say, hey, did you get your allopurinol? Are you on your medication or your inhaler? Did you get your asthma medication? To making sure, because one of the things that's really sad is that we talk about the disparities. There's a desert of pharmacies. So reason the patients don't get the medication sometimes because they don't have a Walgreens or a CVS right down the street for them. They're closing up. There's not a Sam's at Costco. There's no bus that goes to Costco. So a lot of these patients, but we need to use digital tools to reach out to our patient. That's just one area, because that patient doesn't get that acute medication, they'll end up in another episode in the emergency room, and that's where the outcomes and the costs go up.
I think that's a really good point as well. Thank you so much, Alvin. I've got a question, Rima, for you. Can you tell us about some of the alternative care approaches that you've worked to implement at Corewell Health, and how you think these could be implemented across the country to impact the future of care?
Yeah, Joanna, I think all of us throughout the nation have struggled with staffing, and I mentioned that, and workforce, especially during COVID time and post-COVID. We're still trying to recover from that. And really, one of the things that came out of some of the work we did was when we didn't have enough physicians and APPs staffing one of our regional walk-in clinics, what we were able to do is use our title clinics. So we had title clinics, and the physician or APP were in a completely different geography, but the patients would come into those walk-in clinics or urgent care, and be managed through Title clinics with a provider in a different location. So in the past, what we were doing is we were closing down those walk-in clinics and telling the patients to go into the emergency department. But having those, and then since then we have expanded this even further because it has been so successful, we have really kept our patients out of the emergency department and really have been able to provide that access for our patients. So that is one of the things that we implemented. And I think I mentioned remote patient monitoring for chronic disease management. We have a partner, Cadence, and working in managing diabetes, hypertension, and specifically patients with congestive heart failure and trying to keep them out of the hospital, especially when we have had such significant work in the hospital to reduce length of stay. So we are discharging patients with heart failure earlier, still stable but wet, not dry like we used to always make sure that the patient is bone dry before we send them out. Now keeping them in the hospital is actually more dangerous to keep them, and so we're discharging them earlier, but making sure that they have follow-up appointments and can be done virtually as well. And especially having that remote patient monitoring helps us keep the readmissions down. And then we also have a virtual urgent care, which is 24/7. And we have a big effort around reducing unnecessary ED utilization so that 24-hour, 7 days a week, virtual urgent care has been such an important access point for our patients, and also helping the patients, the convenience is a big issue. They don't have to wait in the emergency department, and also unnecessary cost of care goes down with that too. And then, of course, e-visits and asynchronous care with e-consults. I think e-consults have been so successful in our primary care practices because sometimes the wait for some of these specialties, I know rheumatology is a big concern, or access is so hard to get in. In our diabetes and endocrinology, we had 3,000 patients waiting to get into diabetes and endocrinology. And since we had e-consults, which is from provider to provider consults through Epic, we have actually now 0 wait time for diabetes and endocrinology. So there are so many exciting ways that we can really implement these to help with access for our patients as well. And then I would be remiss if I don't mention one of the really important things that we did for our providers was the inboxologist program, which is we hired APPs that just do in-basket work. They don't see patients, but what it does is it allows the other physicians and APPs and the practices who want to see patients and open up more access for them. And we have really expanded that. We started off with a few practices, and it has been so successful. It has shaved off 2 hours of documentation time. Our providers are saying, I am done with my charting by the time I leave my office, and I don't have to go home and be worried if I miss something in my in-basket for a provider. So that has been so well received and has helped with burnout that we are expanding that throughout our medical group.
Thank you so much, Rima. And I think that's a great example of providing support, and whether it's digital or otherwise, where it needs to be, so that the clinicians who want to see patients can do that. That's what they train to do. But then they have this support instead of, feeling that they need to be secretaries or need to do so much paperwork. Stephanie, with your leadership in enterprise telehealth at Orlando Health, how are you ensuring that telehealth is both scalable and sustainable, particularly in post-hospitalization, which you mentioned briefly when we were speaking before?
It's a really great question. I think the key to any initiative, whether it's existing or it's brand new, you got to gather value and buy-in for everything that you're doing with your stakeholders, especially in those early stages, to make sure you're successful. I use this term a lot, if you build it, they will come, is only partly true. So I think if you are really striving for that virtual field of dreams, you got to get value and buy-in, and consider starting small and starting with pilots. We love to do pilots here at Orlando Health. Dip your toe in the pool and test those waters. Don't be afraid to flop or fail. I've done it many times myself, and I think telehealth and technology kind of allows you to think outside that brick and mortar to the click and mortar box a little bit more and get really innovative. And some things just, won't work out, but many do. And I think there's so many really great industry peers and colleagues. Many of those are on this call today that I even connect with. And we got to share amongst each other and, talk about what works, what doesn't work, and why didn't that work for you, and learn from each other so that we aren't all recreating the wheel. I think is essential. But once you get that leadership buy-in, you have to continue to message those strategic benefits, virtual or digital. And I have found it's really key to align with a clinical champion, such as a physician or an APP, to really advocate for the use of, whatever you're trying to implement, and the program development as well. I think that's key. Even being a registered nurse, I can only go so far and really need those clinical champions to come in and help us drive those clinical decisions as we move forward. And even in the post-acute space under a few of my departments, we have dedicated and paid clinical champions that dedicate a certain amount of hours per month to make sure that, we're keeping in line with our quality initiatives and our safety initiatives, and we're driving progress and improving outcomes as we align with many things. I think in our organization right now, the hot topic is readmission efforts. And I think in addition to all of that, I have a key focus on making sure that we provide a frictionless experience to not only our staff and providers, but also our patients. And our software and tools have to be easy, intuitive for all of our staff to use. And I think it's really key as healthcare leaders, you really need to align with best-in-class solutions, and consider the folks who are using your software, because that can create inefficiencies. It could cause frustration and unneeded burden, for everybody involved. And you really want that seamless experience for patients, or else, they won't come even though you've built it.
I think those are all really good points, especially about the usability of anything that we build. And I also really liked what you mentioned about sharing ideas, because I think this is such a new area and everyone's innovating, and it's really exciting to see what everyone's doing. And I definitely think by sharing ideas and sharing successes, we actually held a forum a few weeks ago for some of our partners who have school programs. And it was really small and intimate and so successful, because everyone came out saying, wow, I learned so much from everyone else. We're all doing similar things. We're doing them across the country. Let's pool our ideas so that we can all learn from each other. So thank you so much, Stephanie. Alvin, as the Midwest Regional Director for Rheumatology at AAH, how are you using technology or telehealth to enhance specialty care access? Obviously, particularly in rheumatology, where your focus is, where ongoing management is critical.
Well, I can tell you, Jordan, one of the reasons I like doing these webcasts, because I always learn from my colleagues. So Stephanie, I'm going to borrow that phrase of virtual field of dreams, because I think that's really what we are. So as a department director, one of my big taglines is, don't tell me no, tell me how. So as all the directors for all the specialty departments, endocrinology, dermatology, infectious disease, we all got together last year and said, hey, we have an issue. Our group was spending $5 million a year to cover locum tenens. Like Dr. Shaw said, I don't have a rheumatologist down the street in every single city where we have a clinic. So they bring in a locum tenens. So instead of that doctor costing $300,000, it can cost $400,000, because $100,000 goes to the locum company that hires that doctor. So they say, come up with a solution how we can decrease that $5 million spend. That's a lot of money. We could do a lot of other things with those services. I said, raised my hand. I said, let's take it on in rheumatology. So gave a 30-day notice. We got rid of all of our locum tenens in 2 of our different cities and replaced it with title care. So we have a patient who had an appointment, let's say at 10 o'clock with the rheumatologist in the rheumatology clinic. That patient shows up in the rheumatology clinic. The nurse checks that patient in, and I will get a ding on my computer, secure chat through Epic, hey, the patient's ready, checked in, ready to go. And I connect with them in title care. We're doing all this stuff. And we've done that with both new patients and with follow-up patients. And already we were decreasing that $5 million spend. We got it down to almost half. So I was a test site. Don't tell me no, tell me how. Dermatology is doing it, pulmonary medicine, endocrinology, all of them beginning to do it. I had some of my physicians that were kind of worried because some of them on RVUs, the more patients they see, the more they make. They don't want their production to go down. I said, guys, wait a minute. If you do your virtual visit and you put in a complex medical code G2211, you get almost the same amount of reimbursement as you would see in face-to-face. And this is why having support for the ATA, we don't want to go back to the old days, 2018, 2019, having 30 patients in a lobby waiting to get in to see me. I can do all this stuff virtually and deliver this to great care. Dr. Shaw talking about 3,000 patients waiting to see endocrinology. Those patients need to have an iPhone 7 dropped in by a drone, get up a virtual visit, get a continuous glucose monitor, send those numbers in. And the ones who are sick, they need to be seen tomorrow, next week. The ones who are stable, the hemoglobin A1C is 5.8 and they're good, no issues at all. So we talked about doing the same thing in rheumatology in our department, using title care. Say, hey, if your disease activity is under control, let's keep you where you are. I'll see you back now. The luxury of having patients coming every 3 months are gone. I'll see you back in 6 months or 9 months. But if you're having a flare, your disease is active, before I put you on another $100,000 or $200,000 drug, let's see what else is driving it. And in many cases, we found, hey, they're not getting the medications. They have other stressors that are going on that's triggering their disease. So simple changes like that. Having an issue that came up in our department, that $5 million span for all of our other specialties, and say how we can leverage the digital technology, including title care, that's really been huge. So now we've expanded. I think Stephanie talked about having APPs. Now we have a nurse practitioner who's doing that visits. Other physicians are doing those visits. And that's really kind of revolutionized how people are thinking about providing virtual care. And the final comment, I think Dr. Shaw mentioned this as well. I've been with this group for 5 years. I cover 4 hospitals. You know how many times I've been into the hospital? It's 0. We do an e-consult. I have the hospitalist on the line. I have the patient, and I'm on Epic. I'm entering my orders. I'm telling them, hey, look in the mouth, ears, nose, throat, look at the skin, and do all of those things you need to do. So another tagline of mine is, if there's not a shortage of rheumatologists, there's a shortage of using us efficiently. I mean, unfortunately, I use the example, long COVID. I know it's a real thing, but I have no drug to make that go away. I can't see that patient tomorrow. I might see them in a month. Rheumatoid arthritis, uveitis, juvenile arthritis, they have active disease. That patient needs to be seen within 7 days. So we have actually begun to tier who needs to be seen. We use an AI on Epic to say, hey, the patient have a SED rate above 40, they have a family history, they have a change on x-rays, that patient is an automatic consult within 7 days. If they don't have all those features, who's going to be a tier 2 patient and who's going to be a tier 3 patient? I've seen pain doctors, 7 rheumatologists, and now they just want to come in and see if they have hypermobility. That's not somebody I'm going to see in 2 weeks. I want that kid who might end up with crippling rheumatoid arthritis to get them under control. Everybody thinks this is all futuristic. This is being done right now. It's easy to do. The cost is there and the reimbursement is there. Don't tell me no, tell me how.
Thanks so much, Alvin. I'm going to start saying that to my kids, actually.
Yeah, good luck.
Rima, I want to go back to you with my next question. As the Chief Medical Officer at Corewell Health, how have you leveraged ambulatory care and population health strategies to improve healthcare access?
Yeah, I will build on what Dr. Wells just mentioned. I think what we have done, if you look at traditionally, what we do is we have a patient who calls and you schedule an appointment and they have to come into the office. They are put in by an MA and then the physician comes and then we say, come back in 3 months, right? That doesn't work. This is the peanut butter approach. We need to move away from that. Really looking at our populations and then segmenting them depending upon what are their needs. In the past, what we did, we had a care manager, a pharmacist, a social worker, all embedded in each one of the primary care offices. But there are certain practices that really did not use those resources. And there are other practices that the population of patients they were seeing needed more than what we gave them. So what we really did is finding out, segmenting our patient population, seeing what their needs are, and then providing the resources based upon what their needs. Let me give you an example of a practice called the Community Medicine Clinic, which is in the heart of Grand Rapids. and the patient populations that they serve have a lot of barriers and social determinants of health that have created a lot of disparities. And they have a lot of pain, chronic pain issues, behavioral health issues that have not been dealt with, and homelessness, transportation issues. And if we tell those patients to come on a Tuesday at 8 a.m. For an appointment in 4 weeks from now, they're not gonna, they don't even have housing. And how are you going, or transportation, to tell them a month ahead on this day to come for a visit on this time? That doesn't work. So we created a clinic where you can walk in and we will work you in whenever you can. And how can we also provide you housing, by the way? We can give you temporary housing until we find you a housing that we did a pilot on and really provided housing for some of our patients. What happened? Their A1Cs improved, their heart failure readmissions decreased, their blood pressure improved. So I think those are the kinds of things we need to start thinking about. And then the primary care providers that were embedded in those practices are providers that have dual certification or training around substance use disorder. So they could provide that care to those specific patient population. We had physical therapy embedded, we had pharmacists, we had community health workers in that. Now, when you look at these resources, we don't need them in other practices. Maybe they need something else. And that is how we provided access. There are team-based care where APPs can see certain patients, physicians can see some patients, and also moving away from every patient needs to see a physician or an APP. They can see a care manager, they can see a pharmacist, they can see a social worker if their medications that we just adjusted and want to be seen by a provider, it can be some other team member. So I think using our team members to their skill set will open up access for the right patients to be seen by the right provider. So that's one. And then also looking at different ways of providing access. For example, remote patient monitoring. I mean, if you are asking the patient to come 3 times a year, what happens to all those other days and months in between where we don't have any clue what their health is like? So remote patient monitoring, virtual, e-visits, MyChart messages, going into patients' homes. There are certain patients that we have created home-based primary care because that's what they need. They cannot even, they're so frail and fragile, they can't even come in a car to a doctor's appointment, or they don't know how to use virtual technology. Can we take it to them? And can we go to their houses? So we have to think very differently, providing different ways of access. Access means different for different patient populations.
Thank you so much, Rima. Stephanie, can you tell us a little bit about programs that you're working towards that are helping Orlando Health develop care or provide care to cross sections of the population?
Yeah, absolutely. Orlando in Florida, it has one of the largest convention centers in the United States. And of course, we have Disney and Universal. So if you can imagine, we have a lot of visitors coming to a very busy airport. And so we partnered with Visit Orlando, and we were able to enable a virtual care center in the lobby of the West Concourse to better serve and provide care to those travelers coming in for very large conventions. And many of those are international. So if you can imagine being an international convention attendee, and of course your primary care providers across the pond, who are you going to call for care, especially if it's a low acuity type issue? So by just providing very simple telehealth technology into a well-equipped private space, thousands of folks can really grab care when they need it in under about 3 minutes. And within the last year, we also leveraged TytoCare to bridge that remote exam gap that we have with the typical just video connection. And so we've had a lot of really great success and feedback with just deploying a little bit of technology there. And even our patients are very impressed with the experience that they have and being able to come somewhere that they're not familiar with. And instead of Googling where is the nearest urgent care or ER that I can get to? They can get care right where they need it, right when they want it. And then we also have, various marketing throughout the concourse as well. So you don't have to come to our virtual care center. You can grab that care on the go with QR code, go to our website and get that 24/7, 365 in all 50 states. With all of the non-convention attendees that we see, again, there's a vast majority of visitors are going to Disney and Universal. And we can provide that low acuity virtual urgent care service to those folks as well. So you don't have to, peel your family out of the hotel and, drag your kids to the urgent care. You can, save yourself that headache and get back to the magic of our city a little bit more quickly than if you didn't have those virtual tools available to you. And I think it's important too that you have, the ability to serve those populations of folks. Again, like we have a lot of international, a lot of, different cultures, different languages, and making sure that our services, meet the needs from a primary language perspective, and really threading in ease of use with the interpreter services and the education on our website and those types of things, and just trying to really better serve those populations of patients. And I think, we've had a lot of attention on Florida as of late with, two very, large hurricane events that have happened. Unfortunately, Helene and Milton, did, devastate, some of the West Coast, and even bringing up, towards Dr. Wells. And he'll have some interesting use cases there to talk about here in a minute as well. But with natural disasters impacting, I think, anywhere in the country, I think as healthcare leaders, we need to make sure that we have these tools to better serve our communities. And for Orlando Health, we're able to easily, very quickly activate free low acuity virtual visits during these natural disaster events to make sure that we can provide that equitable access to care in a quick way, and just make sure that we can, extend our reach, to the entire state of Florida, to those who need it. And especially if you've been impacted by those types of natural disasters, the last thing on your mind is, how do I pay for this, right? So just making sure that we can, give that care to those who need it when they need it, regardless of what your situation is. And we've seen really great feedback and just, really great positive outcomes by, better serving our communities that way as well. And would love to hear about what you're doing, Dr. Wells, in that space. Is Helene, really kind of tracked up farther north than anyone thought, and really there's a lot of folks that are still without access to care as well.
Really true. Joanna, I think you do have a question for me, and I can adjust what Stephanie just proposed to me. Or
yeah, I mean, I think it'll be really interesting to hear a follow on from Stephanie, if that's okay with you.
Yes, and about the specialty care. But before I do that, so Dr. Shaw, I would vote for you for senator or president. I mean, some of the stuff that your group is doing, it really brings tears to your eyes. It tells you that we really do have a need, and we have a lot of people in our community that we take for granted, that it's a sin in a country like this. They can't get the diabetes, blood pressure medicine, asthma medication, and that they're homeless, and it rings for us. I know in some states they don't want us to talk about D&I, but it really is a big thing. And when we talk about this, Jordan, I go back to when I first saw about Tidal Care. It was years ago, and I said, yeah, this is neat. It's a little funny looking machine. Looks like a dermoscope and everything. But oh my gosh, when I got my hands on it and I had the nurse doing the visit, I could see in the nose, I could see the throat. Like for us, we're looking for ulcers from lupus. We're looking for stomatitis from methotrexate. I can look at the skin, looking at skin lesions from our drugs. It really changed my life. It changed my whole thought about how we're doing it. So when I tell people, they think about specialty care, oh yeah, I got to do a physical exam. Here's one thing to think about, guys. Tidal Care and using the resource, it could be like a virtual triage. I can do that examination. Oh, you've got a big nasal ulcer there. Your ANA is 320. You have a family history, and you're a young Asian lady. I need to see you in 7 days, 8 days rather, from the visit I've done this that we've done a virtual visit with. I think you might have lupus, and we want to jump on top of that. If the ANA is 1 to 80, I don't see anything on exam. Tidal Care looks really good. I say, hey, I'm going to see you in 2 or 3 months, unless you develop A, B, C, and D type of symptoms. So that's how we leverage that in specialty care. The only little thing that we still need, I need a good tool to tell me, hey, which joint is tender and swollen? And it's absolutely blown away. I'm going to speak at a digital rheumatology meeting in Berlin in March, and they've actually developed a device and app that I can say, hey, if a patient cannot make a fist, that's a sign of an inflammatory disease. If I can't see the knuckles, the wrinkles there, that could be a sign of rheumatoid arthritis. That with a couple of other features I feed into an AI program, an Epic or whatever electronic record, it'll tell me what to get in. So as a specialist, sit down around the table, say, hey, what are these parameters I'm looking for? Dr. Shah talked about diabetes. That's easy. Doing remote patient monitoring, remote therapeutic monitoring now, that's kind of standard of care. And if people are not doing that, that's where they really will be left behind in this whole virtual world that we're moving toward. Everybody say, I don't believe in AI. Now, you do, AI is being used right now, right? We get the denial letters all the time. Hey, is a patient not getting a bone density test? Hey, a patient is due for a mammogram. You think somebody's sitting on the computer looking, oh yeah, Mrs. Smith hadn't had a mammogram, she's due. That's AI. They're running these algorithms, they see what's out there, and that they're using that for us as well and leverage those things. But I think when you take this digital technology, and this is what we really want to get people excited about it, and when you say, hey, that we want to use this, the models that we have are not working 100% for 100% of our patients, let's sit down and see how we can make it and tweak it a little bit to do that. The specialty clinics are no different than primary care. We have different things that we're looking for, and we can leverage those and leverage the technology there as well. I'm really impressed with see what Stephanie and Dr. Shaw are really doing in their areas, because this is the kind of technology. And the last thing, so when I was at Duke last month, where Helene had just gone through and devastated the west part of the state, and that's where Asheville's completely been wiped out. They found two things to worry about. Hey, will these patients be able to make it to their appointments, or will they be able to make it to the vote? And that's where you dispense the drones. You have these patients that go to these other areas. One thing that we did during the pandemic, because we found in Illinois and Chicago, many people didn't have internet access. It's a lot of money, right? They would go to Starbucks or McDonald's to get online. But then we say, guys, guess what? You have the libraries, the local libraries. So we set up a program at a local library. We went in and taught the patient, had like 60 patients during the pandemic, social distance, everybody had masks on, and we taught them how to do a virtual visit. So now a patient could call up the library, hey, I want to use that virtual room from 1 to 1:30. Now the caveat, they got to know how to log into Epic or Cerner or what eClinical works, and you have to take a grandkid or somebody with them. But they have that room, they have internet access available, the libraries in their communities, and they leverage that. At 1:30, that room is then sanitized by the librarian, and another person can call and use that room. So the resources are there. You just got to think a little bit outside the box, and how do we leverage all these different things? The good news, I would love to, like what they do in Germany, broadband is covered. A doctor can write a digital prescription. A patient goes home with a kit, almost like Title Kit, to do their virtual visits. So all these technologies are there. I think we need to leverage this and leverage what we're doing here on this call to kind of help us do our job better. Joanna?
Thank you so much. We're getting short on time, and I do want to take some audience questions. I want to ask one question first before we move over to those, which is kind of a summary and a look into the future. So I'd love to hear from each of you what you believe are the most critical innovations or policy changes needed in the next 5 years so that we can secure equitable access to care across all demographics and regions. And I think, Dr. Wells, you just touched on one. Obviously, I'm not here to answer the questions, but definitely better access to internet is something that's really essential, I think. But now I'm going to hand over to the people who actually know what they're talking about. Rima, do you want to take it away?
Yeah, sure. I will touch on one. I think the most important is the extension of the CMS waiver virtual, because if we don't do that, it's going to take us back to where we were pre-COVID. And we've made such advancements with that. It's so important that we continue to advocate that there's an extension for that. FQHCs, I think virtual visits for FQHCs has a significant negative impact. And how can we also address that, especially when we are talking about our patient populations that have the most needs and access issues, where virtual can be used significantly to help provide that. So that is important. And then residents, oversight of residents and fellows and other students, how can we expand that so that is also considered oversight virtually if an attending physician from some other place can provide that. So I think those are the few things that would really help to continue our innovation, developing different programs based on some of these policy changes.
Thank you so much. Stephanie?
Yeah, Dr. Shaw, I'm going to add to that. I think, we've seen disparities in licensure across roles at the state level. And I think beyond the permanentization of the extended flexibilities that we're experiencing, I think at the state level, we need to continue to lobby and advocate for compact licensures. And what does that mean for every single type of role? I think that's different from nurses to MDs to, physical therapists. And, we're going to continue to, thwart that access to care if, you live geographically near a border state, right? So, it becomes quite costly to start pursuing your license in multiple states. You can't acquire or hire folks from other states without going through that process. So again, I think licensure is key. And I think, from a payer level, making sure that we have service and payment parity at the state level across the board and making sure it's consistent. We have to make sure that if a service is reimbursable when you're in person, it should be also reimbursable at the same rate, whether that's, done virtually face-to-face as well. And making sure that it's not only reimbursable, but that rate is also the same as well. And I think we see a lot of common myths out there, and I hear this from a lot of physicians, hey, I was under this impression that I wasn't getting reimbursed the same rate. My RVUs are a lot lower, and that's not necessarily true. And I think as healthcare leaders, we need to stay in tune with, at the state level, what the service and parity rules are in effect for you. Continue to work with your payers and making sure that they have equal payment rates. Otherwise, we're going to potentially see some disparities in reimbursement, and folks will tend to go backwards, and we can't go backwards. These are such great tools to provide care, and we have to make sure at the state and the payer levels that they're also aligned as well.
And Dr. Wells?
I do a short answer, so I want to get to some of the Q&A. So when Andrew Yang was running for president, my kids were really pushing for him, because I think he had proposed that every citizen gets $1,000 a year, this kind of rebate type of card. I took that a step further, and somebody said, what if we had $1,000 a year that would go to the medical care? Think about it. I think it's a sin. You see patients come in, they got tape on their eyeglasses. They've got a cane that they've made by hand. They got to wait 2 hours to take a bus, and then they got to wait 3 more hours for the bus to pick them up. That $1,000 could be used for the eyeglasses, for the cane. That $1,000 could be used to get an Uber to get them to the clinic. So I think we need to do all those kind of things. That $1,000 could be used to get a refurbished iPhone 7, $99, that has a digital card on it. They can do their televisits and everything with it. So we got to think about how to use these things. I think Dr. Shaw said it. We don't want to go back to the old days, which is 2019, right? We want to continue to move forward, advance these technologies, and we have the tools and the resources to do it.
Thank you so much, everyone. I'm gonna take a look at some of the audience questions. We don't have very long, so we might only get through a couple. But let's start with this one. What do you see as the biggest barriers in digital adoption, especially from a payer's point of view, and how are you addressing this?
I think one thing that they're concerned is going to be some abuse. And that's what we talked about during the pandemic. Hey, am I going to see a patient every 7 days since I know I can get paid for that? No. We're going to say we're going to use these things appropriately. And like Stephanie touched on, we don't want to go back. I should be able to treat patients wherever they come from. They shouldn't have to wait 6 months to see a rheumatologist in Michigan, where I can see them next week in Wisconsin. So that's the kind of thing that we need to kind of get smart about.
Thanks so much. Rima or Stephanie, do you have anything you want to add?
I think Dr. Wells summed it up really well. I think the other, from payers' perspective, I would think that reimbursement, I think, would be an important piece of it. And then making sure, one of the other things, if I take it from a provider's perspective, I think that was initial concern that you may not be able to provide the care that a physical exam or in person you can do. And I think with so many other tools that are available, TytoCare is a great example that you can do a pretty darn good exam, listening to the lungs, looking into the ears, the mouth. That was one of the things that I had heard significantly from providers, and now we have solutions for that. So I think as we continue to advance that and continue to get better with our technology, that reluctance to jump on, we will be able to overcome that.
Thank you so much. Let's try and get one more audience question in before we have to call time. There's a question here: how do you mitigate the use of technology with patients or populations who are not tech savvy or who may be reluctant to use technology?
I can give you a little bit of how we have tackled that. So I think what we did was really when the patients come in to see a primary care provider, we provided like hands-on training to the patients, because that's the best time, the golden time, when you have the patient and really help them walk through it. We also created tech hubs and even mobile tech hubs that would go into the communities and helping patients set up virtual, or if they had any questions, or how does their iPhone work, how do I download Title Care. I think all of that really helped. And then there are some other places where we actually sent MAs into patients' homes and help them with those. The other thing is they can come into an office, like a Title Clinic, where you have the staff to help with that technology as well. So different ways of helping patients to overcome that barrier.
Yeah, Dr. Shah, I think you made a great point. And in addition to that, I've done some work in making sure that the support staff are very well educated on the workflows, and especially the patient view. If your patient portals are the gateway to that access to virtual care, you have to invest the time and energy to make sure that the staff who are supporting the patients who may call the office are very well versed in what that patient is navigating through, so they can help troubleshoot, or even sometimes you see staff becoming IT tech support almost to some degree, and just making sure they're equipped with the basic skills to get a patient through that virtual encounter. So I think is really important.
Joanna, just add on that real quick. I think Dr. Shah mentioned earlier on about how you're using nurses and pharmacists as well. And I think in many places overlook that. They're part of the four-legged stool: the physician, the nurse, the medical assistant, and the pharmacist. All of my drugs require a lot to spend over time going over side effects. Guess what? I had the pharmacy team go in there with them. If the pharmacist is not on site, then I have an iPad we bring in, almost like we do for a translator. Say, hey, the pharmacist is going to go over the side effects of all your drugs, and this is what you can expect. I'm already seeing another patient. So don't forget to leverage your team that you're having as well. And in many places, if you don't have the pharmacy team, you can connect with a national specialty pharmacy that can do it for no cost. And so we'll talk about that. So using these other resources like Stephanie's talking about.
Great. Thank you all so much. This was a really fascinating discussion. I really appreciate your time and all of your insights. Thank you to all of our attendees. And thank you very much to ATA for hosting us today.
Thank you.
Thank you.